my focus has been on sort of interpreting the clinical data that we have with immune therapy and trying to step back and assess whether or not there's a way to try to understand who the patients are who get really sensational benefit from these therapies. Where going forward, if we knew how to identify such patients, as they walked into our clinics, we would very confidently offer them these exact therapies versus those patients who are not going to get that type of benefit. Now, we really face a bit of a problem right now in the development of next generation immune therapies, where we are conducting clinical trials without this knowledge. So we're including some patients who are going to benefit from, for example, a PD-1 antibody by itself. We're giving them a combination of a PD-1 antibody plus a new drug. If we knew who was who in the population, we'd be able to say, oh, this is fantastic. We're seeing a response to the combination therapy in a patient who would not have responded to PD-1 antibody alone. And that would allow us to much more quickly nominate new therapies to take forward in further clinical trials versus sort of put them aside and say they're not doing their job. So the issue of being able to discriminate between potential responders and non-responders is of very real value in routine clinical practice in terms of offering patients these therapies and not saying to them, you have in certain cancer types a 20% chance of response, which means an 80% chance of non-response, 40% chance of response. These are really unsatisfying numbers, to be honest. And so the power of being able to take the outcome data and do research for molecular features or any type of characteristic of the patient's cancer or the patient themselves to be able to get to numbers of 80, 90, 100% confidence to say, okay, you're the one who's going to have a fantastic benefit from this drug as it is. We don't need to worry about clinical trials. Versus, unfortunately, you're not the one, and we really have more work to do, and we should be talking about clinical trials to test new approaches. I think physicians in clinical practice are talking to their advanced cancer patients, weighing multiple treatment options. Some of these are chemotherapeutics from decades ago. Some of them might be molecularly targeted drugs. And then now increasingly immune therapies are part of the landscape for an increasing number of cancer types. And so physicians are looking at each of these therapies and wondering, how can I estimate for the patient in front of me what's the most likely to work for them? And then, of course, balancing that with side effect concerns, and in discussion with the patient, try to come up with a customized approach. It feels really unsatisfying to look at our available therapies and estimate the possibility of response based just on 1,000 patients worth of outcome data for all lung cancer patients included in a clinical trial without any ability to personalize. So we've gotten very used to personalizing targeted therapy, particularly those that follow mutated targets, where you test for a certain set of mutations. If you find one of them, that's an option. And it feels like we should be able to get there for immunotherapy, to follow the same exact precision medicine concept. It's just going to take different types of markers than simple mutations pointing to single drugs. So I think clinicians are looking for that in their practice. We're already seeing sort of this demand or appetite with tumor mutation burden as a marker that's part of next generation sequencing panels, and many clinicians using that in their discussion with patients in terms of treatment options. I think we have a long way to go to come to really more powerful predictors, but I think practitioners are voting with their feet in terms of how it is that they would like to better predict for their patients which of these treatments is going to be most advantageous. So the beauty of the climate we have at Mass General in terms of clinical research and laboratory-based research and pathology collaboration when it comes to this concept of biomarkers and elucidating outcomes is that we have really quite a cross-cutting culture. And by that I mean that we don't tend to think of lung cancer versus colon cancer versus melanoma as being totally different entities. We almost start from the opposite assumption, which is we assume that there probably are some common themes across cancer. Let's try to find those, because the more we can develop therapies and biomarkers that would allow us to be able to help swaths of cancer patients across cancer types, the better. Just the better for patients, more quickly. And there are probably some discoveries we may never make if we stay within a cancer type silo. So this is the culture that's existed at MGH since it really took on scientific and translational research now 15 plus years ago, and we've maintained that culture. So I would say that is our power in terms of being able to contribute to the field.